Today we're going to be talking on evidence-based mechanical diagnosis of SIJ dysfunction, please. We want to look at criteria for making accurate mechanical diagnosis for the problem associated with sacroiliac joints, which otherwisely is known as SIJ dysfunction or SIJ torsion or SIJ irritation. My name is Oluwaleke Ganiyu-Shokunbi. I'm a professor of physiotherapy from Bayero University in Kano, Nigeria. This is the part of the body, or this is the region of the body known as sacroiliac joint. Let's show it on this bone model. So this is the sacroiliac joint. It is made up of a number of irregularly shaped bones. We have the sacrum, which is like a V shape. Then we have the ilium, which bind with the innominate, and the innominate articulate with the sacrum here. So we have the first sacroiliac joint here. We have the second one on the other side, the sacroiliac joint here. So it is made up of a series of irregularly shaped bones on the right and the left side of the body. The reason why one of the reasons why it is so important that we know how to diagnose the sacroiliac joint dysfunction as a physiotherapist is because as physiotherapy, we see a lot of patients with low back problems, yeah? And majority of them or maybe quite some few of them have their pain generator from the sacroiliac joint. The pain they are feeling in the lower back actually is coming from the sacroiliac joint area. So if we are unable to diagnose it, we'll keep treating the lower back, the pain will go down, and then the pain will come back again. So in a broad sense, many of the pain in the lower back can either come from the spine, or come from the hip joint, or come from the sacroiliac joint. So what is ideal for a physiotherapist to do if a patient comes with low back pain problem is to assess and diagnose from the point of assessment of lumbar spine, the hip joint, the sacroiliac joint, and even muscles around the pelvic area. Studies have shown us that out of every 10 patients with low back pain, 1 to 2 of them have their pain coming from the sacroiliac area. So it is very important for us that we are able to make a very accurate mechanical diagnosis of the sacroiliac joint. Now, before we talk about the diagnosis of the sacroiliac joint, let's have a look briefly at the anatomy of the sacroiliac joint once again. The sacroiliac joint, just like we said again, is made up of the ilium and the pubic bone. The ilium comes to the front to form the pubis, and it comes posteriorly to form the ischium and the ischial tuberosity. We have the nominatum here, we have the other side, the nominatum here, and we have the sacrum bone here. So this is the right sacroiliac joint and the left sacroiliac joint, regularly shaped bones. Now, because of the regularly shaped nature of the sacroiliac joint, it needs a lot of muscles and ligaments to support it. So it has handful number of muscles here and ligaments to keep it in place. So many at times, the problems associated with sacroiliac dysfunction has to do with malpositioning as a result of compromise of the stability of the joint. Maybe the joint is not well positioned, or maybe the joint is stopped in one form of movement or the other as a result of problem with the muscles or the ligaments. Another anatomical point of interest about sacroiliac joint also is that it has a complex plexus of nerves coming from X2, X3, and X4. And because of that, the pain here, even though the movement is not much, but the pain or dysfunction in the sacroiliac joint could produce a very excruciating pain that could affect the function of the patient in no small measures, okay? Now, talking about the movement in the sacroiliac joint, principally, because the joint is formed by sacrums and ilium, there are two types of movements. There is a kind of rotational movement that could take place at the sacroiliac joints, and there could also be a translational movement. I think this would be a better model. Look at the sacroiliac joint. There could be a rotational movement and there could be a little translational movement. What sort of rotational movement could happen? By the time the sacrum rotates anteriorly, the sacrum could rotate anteriorly, thereby forcing the ilium to rotate posteriorly. That will be called anterior rotation, which in other words is also called counter nutation. Or the sacrum can rotate posteriorly. If the sacrum rotates posteriorly, whereby the ilium rotates anteriorly, that will be called posterior rotation or nutation movement. So basically, there are about 4 degrees of rotation which will take place in the sacroiliac joint maximally, either in the counter nutation direction or anterior rotation, or nutation direction or posterior rotation. And there could also be about 1.6 millimeter of translational movements forward and backward going with that rotation. Okay, right. So just like we said, a lot of problems with the sacroiliac joint could cause problem in the lower back. A lot of problem in the lower back could cause problem in the sacroiliac joint area. So it is very important for a therapist to know how to make a diagnosis. So how do we make diagnosis of any joint? If we remember what we learned in the medical school, to make a diagnosis, we have to do subjective assessment, we have to do physical examination, we have to do some special tests, and we can also order for some special investigation. We can do radiological investigation, we can do hematological investigation. And by the time we put all these findings together, we will be able to make a diagnosis. So even today, we are going to discuss the diagnosis of the sacroiliac joint from the point of subjective assessment, from the point of physical examinations, and some other relevant procedures. Okay. Now, what about the subjective assessment? When a patient comes to us in the clinic as a physical therapist and is complaining of pain in the lower back area radiating to the buttocks, patients with sacroiliac joint pain will normally come to your clinic and complain of pain below the region of L5. If the pain actually is coming from the sacroiliac joint, it must be below L5 because sacroiliac joint starts from the first sacrum. So any patient that comes with the pain and puts his hand very in the lower back below L5 and with the pain radiating to the buttocks area or to the back of the thigh, or the pain could be radiating to the front, to the side and to the front, to the pubic symphysis and to the front of the thigh, or even to the groin area. When a patient comes with that pain pattern and is making such a complaint, we might as well begin to think that this patient could be presented with a problem of sacroiliac joint dysfunction. We will not forget, the pain will be below L5. The pain could be radiating to the buttocks, it could go into the back of the thigh, it could come laterally, come anteriorly, it could even be going to the groin area, right? So that could be the first indication. So the pain and the pattern of pain radiation during subjective assessment could be giving us a clue as regard what could be diagnosed as sacroiliac joint dysfunction. But apart from pain, patients also will often talk about instability in the sacroiliac joints. Now, the patient could mention the fact that when they are walking, they feel something is going to give way, and they experience that something giving way in the region of the lower back or in the region of the pelvis. They think their pelvis is going to fall apart, or even they feel the leg on the other side is going to give way. We call this instability in medical world. So two major clinical features or chief complaint that a patient with sacroiliac joint disorder will often come with is the pain which is below L5, which could be radiating to the buttocks area, going to the back of the thigh, going to the side, to the front, and to the front of the thigh. And sacroiliac joint pain is usually unilateral. It is mostly on one side, but it is not impossible to find it on both sides. But what you will never find is the pain going through the midline or the furrow of the spine. It's got to be on one side, posterolateral or posterolateral, either in unilateral manner or bilateral manner. Okay, so we've got to remember that. When we have this kind of presentation, then it is very likely that the patient is having sacroiliac joint disorder. The other thing that could make us to start thinking of this during subjective assessment is what we call the aggravating factors and the alleviating factors. For sacroiliac joint pain especially, the major aggravating factor is putting weight on the affected side. So what would the patient say that make the pain worse? Prolonged standing will make that pain worse. Prolonged sitting, putting weight on that part of the body will make the pain worse. Importantly, the patient will not be able to lie on that side when they are sleeping at night. And that still has to do with weight bearing. Transiting from sitting to standing will be very difficult for that patient to carry it out. And when patient is going up on the stair, putting that leg ahead of the other one, it could be extremely painful. And some little activities of daily living like putting on the pants or putting on the socks could become extremely painful. So when we have all this complaint, the shift complaint from subjective assessment, we might as well begin to think that the patient is having sacroiliac joint dysfunction. But in terms of evidence, how strong is the evidence behind using this fact from subjective assessment in arriving at the diagnosis of sacroiliac joint dysfunction? The response is that the evidence is very weak. The evidence is very questionable. We cannot use this mere complaint of patients to arrive at an evidence-based diagnosis of sacroiliac joint dysfunction. You want to ask me why it is like that? Because all other pain generators in the other parts of the body could also present with the same thing that we have said. If a patient is having disc problem in the lower back, it could also present with the pattern of pain that we have already mentioned. If a patient is having tightness of the piriformis muscles, it could also be presented the same way. If a patient is having tightness of the rectus femoris at the front, it could also be presented. Just the same way a patient with sacroiliac joints will make his complaint. So when we're talking about shift complaint, they are good pointer that could make us to begin to think that the patient could be having sacroiliac joint problem, but they are very questionable in terms of establishing a strong evidence for the diagnosis of sacroiliac joint. That means there will still be a need for what? Physical examination, some special tests, and perhaps some other procedures which we are going to discuss in subsequent videos. But in terms of subjective complaint, we'll be looking for pain below the region of L5, which could be unilateral, bilateral. It could radiate to the buttocks, to the back of the thigh. It could come to the side. The pain could even be radiating to the front, to the pubics, or to the groin. Okay? The pain is usually aggravated by weight bearing, and pain is usually relieved by having an external support on the pubic bone. The external support could be in form of hand, patient doing that to himself or herself to get some comfort, or it could be in form of a brace, a lumbosacral corset. These are the relieving factor, but the alleviating factor is extreme weight bearing on the affected side. We will be discussing the other factors that are needed to making evidence-based diagnosis in subsequent videos.